Hello, everybody. Welcome to the Global Response to COVID-19 webinar session 2. This webinar is sponsored by the Pan American Trauma Society in collaboration with the American Association of Surgical Trauma, International Relations Committee, the World Coalition for Trauma Care, and supported by University of Miami and Virginia University. I would like to welcome all the panelists and everybody that's attending this conference. And just some rules. Every attendee can make questions. Please press the box where you have the words Q&A and put your questions over there. Also, please send your question to the panelists. And the panelists also, please, we can interact with each other and can make questions to the two presenters for today. So, Dr. Abutanos, could you please introduce the other panelists, international panelists, please?
Sure. We additionally have Dr. Ken Bofard from South Africa and Dr. Tina Gardner from Norway. We're waiting to be joined by Dr. Otomo from Japan and Dr. Ingo Marzi from Germany as well, and Dr. Ian Civil from New Zealand, if they could join us. As well as we already have Dr. Coimbra, Dr. Rizzoli, and should also have Dr. Scalea on board as well.
Perfect. Okay. So let's start the presentation. I would like to invite Dr. Zhang to do the presentation. Dr. Abutanos, could you please introduce Dr. Zhang and give his credentials, please?
So we have Dr.
Okay. Hello, I'm Dr. Zhang from China. Can you all see the screen? See my PPT?
Yes, sir.
Okay.
Go ahead, please.
So
Okay,
Dr. Zhang is from the Hong Kong University.
Sorry, I couldn't get off. Dr. Zhang is our deputy director from the Ku Shawan Trauma Center. He's from GI surgery and in ATLS education. He is both an educator for ATLS, as mentioned, the point of surgery, again, University of Hong Kong Shawan Hospital, and a member of the International Relations Committee at the AASD as well.
Okay, thank you. Thanks for your introduction. So today I'm going to talk about COVID-19 in China, and I'm going to share it from Shenzhen. I'm going to talk about the current situation in China and what China has done in the past 3 months and the key points. And the current situation in China at the moment, we have current diagnosed patients is more than 5,200. At the moment, the current severe patients is more than 1,500. And we're getting more and more patients coming from outside. We have now have 427 patients from outside China diagnosed with COVID-19. At the moment, for the whole country, total diagnosis is more than 81,000 patients for the whole country, and the death is 3,283. Wuhan and Hubei is like the middle of China, and I come from Shenzhen, is like South China, next to Hong Kong. And the first three most patients in the province is Hubei, Guangdong, and Henan. And in Hubei, is nearly 83% the diagnosis patients are coming from Hubei. And for all the deaths, it's more than 96% is from Hubei. And the red line, red curve is for the diagnosed patients. We can see from late January and then going up slowly, and then going up until mid-February, and then suddenly go up very significantly. Because at that time, many suspicious patients are admitted and tested and then diagnosed. So that's why the number increased suddenly and then going down slowly. And the yellow one is the suspected patients and then going up and then going down. The green one is the discharged patient, and the black one is the death patient. And this is for the whole country. The patient is going up from late January and then going up all along until early March. And then after March, and it's getting stable. And And the green one is the discharged patient, the black one is the death patient. This curve slope is in Hubei plot. It's in Hubei also the same from late January and then going up all along and then go to the top at the mid-February and then start to going down. And the green one is discharged one and the death one with the black curve. This is the Shenzhen 20 minutes population. South China is the city where I come from. On the right side, the map shows it every day. How many cases were diagnosed in the city at the moment? We have total 440 patients, and the top cases is going to the late January. 31st January, we got 60 cases per day, and then after that we're going down slowly. And then we have many days we don't have any cases. But in the past 10 days, we get some cases from outside China. So what China has done in the past 3 months, so the first thing is strong leadership from central government. So after the central government decided to fight with the virus, then the national level medical team was set up. And President Xi told the whole country, we need to have strong confidence to fight and win the epidemic. And then 7 guidelines for fighting with the COVID-19 was developed. So the first thing is the leadership. The whole country work as a whole and to consider the local prevention and control demanding and consider how the local situation will affect other places in the whole country. And then to criticize those not doing the right thing and to correct them immediately. For those doing the wrong thing or misconduct, to punish them according to laws and regulation. And the second guideline is strengthen prevention and control in many regions. Hubei continue to strengthen overall prevention and control to continue to prevent epidemics spreading to outside Hubei. For province around Hubei, to press the local government to take the responsibility to set up prevention and control networks at community level. In Beijing, to improve prevention and control approaches, to focus on main groups of population and to reduce moving source of infection. The third guideline is to increase admission rate and cure rate to reduce infection rate and mortality. To build dedicated hospitals as soon as possible, to dispatch medical staff from all over China to support Wuhan and Hubei, to work as a whole to concentrate best medical staff, to concentrate the severe patients, and use the unified arrangement for medical treatment, and also to propagate effective treatment practice for severe patients. The fourth guideline is to increase science and research work to demonstrate where the virus coming from scientifically, to find out source of infection and route of transmission as soon as possible, to strengthen research, development, vaccine, and medicine, and to open and share information and patient data that are allowed to be released by law, and to encourage experts and scholars to take the responsibility and professional liability. And the fifth guideline is to maintain the society stability, to maintain normal economic society order, medical treatment order, and society safety, and then strengthen law and traffic management and control, and to reduce public transportation and pressure and prevent clustering or the cross-infection. For the publicity and education, and the strengthen confidence to fight and win. To increase the positive education, to respond international and internal concerns, and to tell the story about fighting COVID-19 in China and to collaborate with international partners. So the 7 guidelines of the economic stability, where the proper prevention and control work and support people return to work and production. To restart the work on main projects and to stabilize residents' consumption and improve management capacity at national level. So this is to all leading organizations in the country for fighting the virus. The first one is the National Health Commission, and the other one is the Joint Prevention and control mechanism of the State Council to coordinate all the things needed for fighting the epidemic. So this is Professor Zhong Angsang, is the team leader at national level. He met Professor Lipkin in Guangzhou, and they discussing with the strategy or the strategy for fighting the epidemic. Wuhan was locked down in January 23rd at 10 a.m. in the morning. The aim was to localize the infected patients in Wuhan, not to infect too many other people outside and other places. At that time, people saying sadly, they said a brave man to break his own arm and to sacrifice a city to save a country. And on the right side, the map shows is the big wall means to close the city, and the red wall it means if the people is there, the city is there. So it means that put the people, put the health at the first place. So a new hospital in Wuhan was built and finished within 8 days with 1,000 beds. It was in late January for severe patients. And then another new hospital in Wuhan was built and finished within 18 days with 1,600 beds in early February, also for severe patients. This is the hospital look like. Big containers was used for the hospital building. And this is the inside hospital examination machine and CT scan. And another dedicated hospital was built in Shenzhen as well. And in Beijing, they reopened the original hospital. The one is was fighting with SARS in 2003 in Beijing. So mobile cabin hospital also was set up as well for mild symptoms and suspected patients. There's many mobile cabin hospitals was set up. Is about 20, something like that. So totally, the mobile cabin hospital provide over 30,000 beds for patients. It significantly limited the patients together in order not to infect other people. So medical support from the whole country going to Wuhan and Hubei. So from north, from south, west, and east. And also from the military medical staff, and also from Beijing, many hospitals. And different support from nation and from overseas going to Wuhan and Hubei as well. Many medical staff, in order to work inside ICU for a long period, many of them they remove their hairs for easy work inside the ICU. So medical staff from a province in China to help a particular city in Hubei. On the left side, the map shows is the province of Hubei, and then Wuhan is the capital city of Hubei province. On the right side is the map of China. So every city in Hubei is managed by medical teams from a particular province in China. So it's one province to take care one city. So for the medical treatment support inside ICU, getting support from the medical teams from the nation, from Guangzhou, from Hangzhou, and from Beijing as well. That's two handbooks was developed. One protocol was developed as well. This handbook is developed and then is focused on prevention and control management, and also focus on diagnosis and treatment, including ECMO support and plasma therapy and drug use management, and also nursing care as well. If you are interested with the management, I think this book, this menu can provide you quite a lot of good information to refer to. And then if you want to get this handbook, please ask Professor Antonio or Professor Michael. This handbook is focused on the transmission of the virus, such as the transmission in the community level, and also focus on personal precaution. It's important at the very beginning. China is more than 3,000 medical staff when infected by the virus. So the personal precaution in the beginning was not properly. So this is very important for all the medical staff to protect themselves. This protocol is only in Chinese version, no English version. Is the 7 edition is using in China at the moment. Is what we are managing, diagnosing, and managing the COVID-19 patients at this stage in China. It can be downloaded in the website. So at the community level, if you don't have your temperature checked, you cannot go home. In China, every community, everywhere, every patient checking temperature all the time. If you are going home, then if you don't get your temperature checked, you cannot enter your home, something like that. If you have fever, if it's tested, you have fever, then medical staff will come to you. And after further test, if it's needed, you will be sent to hospital for further management. So the key points is for early detection, early report, early isolation, and early treatment. Is to move the control point at the front, to increase the test capacity, to stress the importance of community network management, to find out every suspected or infected patient, to stop or to slow the virus spread. And another 4 concentration is the concentrating the patients, concentrating experts, concentrating resources, and concentrating treatment. It's individual treatment and trying to help every patient. It's putting the most severe patients in the best resources hospital and using the multidisciplinary team approaches and support from the best medical team in China. And the summary is a strong leadership from central government, the whole country to work as a whole, to fight the virus first and trying to provide support for every person and every family, to protect medical staff, to control the situation, and then to recover the economy. At this stage, the government is trying to recover the economy. So the recommendation is adopted the principles. The experience from China is not the only way, but the experience are the same. This is from Professor Zhong Nanshan, is the medical team leader in China, leading the team fighting with COVID-19 in China. So the recommendation for early and for concentration: early detection, early report, early isolation, and early treatment. For concentration, is concentrating patients, concentrating experts, concentrating resources, and concentrating treatment. This is the experience from China. So the recommendation is that every country is not the same and cannot use the same way. And the most important things are the principles. And I hope everyone fully understand the principles used in China and to do it in a way suitable in your own country. Thank you.
Dr. Zhang, excellent presentation, very important. You're going to discuss a lot these afterwards. There's a lot of different approaches in the world. People, some countries are just doing, keeping everybody home. Other people saying that it's not necessary. So your points are very well taken. I'm going to discuss these afterwards. Let's go now for the second presentation. We're going to have here an old friend. This is his 3rd week in a row talking to us. Dr. Hayato Kunihara from University of Milan, Humanities Hospital. We're going to talk about the updates from last week and what's the trend, what's happening in Italy right now. Dr. Hayato, please.
Okay. Hello, can you hear me?
Yes.
You hear me? Yes.
Yes.
Okay. So just a very short update regarding what is going on all over Italy. As you know, we had the first outbreak about a month ago, exactly on February 21st, we had the first case. And that was thanks to the intuition of an emergency physician in the emergency department. And the problem is that we immediately tried to isolate the area, but after 24 hours, probably less, we already had 36 cases. So we immediately understood that we had a second cluster of COVID-19. So, and the virus could really expand quite rapidly. In a week, almost all of the our region was infected. So this is the graph of what's going on in Italy, all over the country. As you can see, just 2 weeks ago, we had just 9,200 people that had an approved infection. Last week, that was March 19, we have 35,700 people. And this is the last update of yesterday. Yesterday, we got 63,000, almost 64,000 people. As you know, the rest of Europe is behind us, around about 10 days just behind us, maybe 2 weeks, the US. And this is the first source the first challenge was the recruitment, as you know, of ICU beds. So, and the progression of the needs of ICU beds was quite impressive. And at the moment, 3,200 beds are occupied all over Italy, and probably much more. The problem is that we almost doubled the ICU capacity in our region, in Lombardy, which is a 10 million region. Was before the crisis was about 460 beds, but we have been constantly running 100% of saturation of ICU beds, and we created more than 600 beds actually in 3 weeks. And now we have about 1,200 beds in our region. So as you know, in Italy, we started to have a containment strategy. So mainly we contained the northern part of Italy, I mean Lombardy. But unfortunately, just before the containment strategy was set up by our national government, a lot of people, these are pictures that were shot about 10 minutes before midnight of the day we started a very strict containment strategy in northern Italy. And that's the result. What happened? A few days after that, we had the spreading of the outbreak all over the rest of the country. And that's these are the results now of a lack of an immediate containment strategy. So nowadays we have, today we have, that's the update of yesterday, we had 62,000 cases of COVID-19, almost 6,000 people that got infected are healthcare workers, and we had almost 6,000 deaths. And the median age of cases is 63. So the most critical patient represent almost 5% of the symptomatic, of the infected patient, and 20% are severe. And most of the cases are symptomatic, mildly symptomatic. So, and this is the graph of mortality. Of course, this disease is hitting elderly people, but still we have some young people that get infected. Just to give you an example, now in this moment in our ICU, we plan to have at the beginning just 4 beds of our ICU dedicated to COVID patients. At the moment, we have 34 patients in ICU. And the average of our patients that are mechanically ventilated is about 64, 68 years old. So we also have young patients that are ventilated. So now we have a very tough restrictions. This is the new law that just passed through our national central government. And now we are very restricted. We have tickets that are running from 400 to 3,000 euro, and imprisonment for people not respecting the quarantine has been also set up, 1 to 5 years. So after we started with some this restrictive policy, this is the Duomo Square, downtown Milan. This was the situation till a few weeks ago, and now this is the result. This is the picture of yesterday of our beautiful square in Milan. So we just started to see the first positive results in northern Italy, but we will probably see in a few days. We hope to see better results in a few days, hopefully at the end of this week. And this is our university. We still think positive.
Thank you, Dr. Hayato Kunihara. Excellent presentation again. I'm gonna open a question for you both, for Dr. Zhang, Dr. Kunihara, and then for the panelists. One of the first slides that Dr. Zhang showed that at some point the curve of new case was start to decrease, but the mortality was still going up. So Dr. Zhang, Dr. Kunihara, so when you start to do the plateau the new case, how long do you still have critical patients in ventilated in the ICU, and how many weeks you want to expect the decrease in the mortality in your countries? Please, your comment for both, and then for the panelists, please.
Yeah, thank you for your questions. A curve increased suddenly. I just mentioned it because the government said we need to increase and admit more as the patients as we can to file every suspected patient, to file every infected patient. So once the capacity is ready, so a lot of patients are admitted and then tested. So the infected patients, the number is increasing. For those very sick patients, they all admitted in the major teaching hospitals in Wuhan hospital, and the medical resources is from many places from China. Unfortunately, I don't have the very detailed ICU patients details because I work in Shenzhen. I don't really working with in the ICU, fighting with the COVID-19 in Wuhan, Hubei. So yeah, unfortunately, I don't have the detailed patients data about how many days in the ICU and how many days for them to getting better. Yeah.
Dr. Hayato?
I'm sorry because it was a little bit noisy here and I couldn't follow and try to move away with it. So I didn't understand the question.
So Dr. Hayato, we saw in China that at some point the number of infections started to decrease, but mortality was still going up. So for how long do you still expect the mortality going up after plateauing the new infection, after controlling the community new case? So what's the average time of the patient in your ICU?
The average time is around about 2 weeks in ICU. That's quite a rough number. Or it's quite a rough number. Sorry, I had some problem with the connection. It's quite a rough number. So the average is about 15 days in ICU. But you know, since now I have to say that the average of the ventilated patient is not that of the age is not that high. So we hope that will be linked to better results, at least in our hospital.
Okay, thank you. Anybody else from the panelists want to talk about this topic? Dr. Abutanos?
Antonio, this is Raul Coimbra. If I may ask a question to both our friends from China and Italy, there is in this phase that we are in the US, the preparation phase, a number of questions have been raised about patient selection. When you have scarce resources and the ethical issues relating to decisions of not providing care or not providing advanced care, such as mechanical ventilation when you don't have enough ventilators. I'm just curious to know how they have dealt with that issue. There are some information coming from different sources, and I'm not sure if they are true, that in Italy they are putting a cutoff time of 80, cutoff age of 80, and providing care preferentially to younger patients that have a better chance of recovery.
Yes, this is one of our main concerns. At the beginning, I know that we start to ventilate also quite old patients, and then this cutoff necessarily had to decrease, because the problem is not the severity. I think that the problem is not the severity of these respiratory failure, but it's the volume of people coming to the emergency department. The volume is really massive. Actually, we had a discussion yesterday regarding ECMO, for example, and I think that in the Milan area, where we had about 600 patients that are ventilated, I think just 2 or 3 ECMO patients. So the problem is, as far as I understood, is the volume of people needing a ventilator.
Yeah, in China.
What about in China?
Yeah, because in China, the most very important thing is the government to lock down the city of Wuhan. Because they lock down the city, most of the patients, infected patients, stay in Wuhan. Is not going out to infect many other patients. This is the most important point. And then under that, the government, they dispatch all the medical teams from all over China, ask all the good medical teams to bring their ventilators, to bring their PPE, to bring any equipment in their hospital is available and helpful for Wuhan and for Hubei. So a lot of medical teams bring a lot of ventilators, bring a lot of equipment to Wuhan, to Hubei. So at the very beginning, they are sorted with the PPE, sorted with the equipment, but very soon, once the teams go in there, bring the ventilators there, bring the equipment there, then it's getting much better. So actually in China, we don't have the very tough option about choosing the patients. We can treat nearly all the patients affected by the virus. Resource at the beginning was shortage, but later it's getting much better. It was manageable during the time.
Okay, I have a question here from Dr. Alan Guo. I'm gonna make this question for the 2 presenters, and to Dr. Scalia, Dr. Raul Coimbra, Dr. Sandra Rizzoli. Okay, so you said, Dr. Zhang, that at some point the city Wuhan was locked down. You said not only to localize the patient that infected, not to avoid spreading the virus, right? And there's a lot of controversy, a lot of people still not agreeing with lockdowns, a lot of people saying that you should do vertical lockdowns, not horizontal lockdowns. So I would like to say, and I know that in Qatar, Dr. Rizzoli, Dr. Peralta they locked down the city very in the early stage, and then I don't know how it's in California, how it's in Washington, Baltimore region. I want to ask you this question. So how, for the 5, so how social distance, what's the role of social distance on the prevention of the spread of the infection? And second, how are you managing PPEs, the protection for healthcare professionals in your area when you have a lot of patients and not all the resources available at the same time. So let's start with our two panelists, then Dr. Rizzoli, or Peralta, Dr. Scalia, and Dr. Coimbra, please. Dr. Zhang, you first.
Okay. So because it was locking down for the city, so it's a very strict policy. So the police and also even the ministry was there. So it's locking down all the ways, locking down. Nobody can go outside the city. All the public transportation, all the cars, all the transportation, all everything stopped, including the airport. And then in the beginning, the sorted with the PPE, and the medical staff they use PPE. It was very hard. Well, the whole day only use one PPE, and some of them they are sorted with the PPE. So that's the lessons we learned at the beginning. So that's why so many medical staff affected at the beginning, because at that time that's not proper protection for the medical staff. For the more than 3,000 medical staff infected, more than 90%. It all happened in Wuhan and in Hubei. So the reason is at the beginning don't have enough PPE. So that's why so many medical staff affected. So later on, there's support from outside Hubei and outside Wuhan. There's people from other provinces, and then things getting better. So this is the things going like that. So the important thing is that if we don't lock down the city, if the people going outside the city and infect many other peoples all over China, so I cannot imagine how can we manage the situation. If everywhere have a lot of patients, it is impossible for us to manage the whole situation. The advantage to lock down the city is because we focalize most of the patients together. They can handle all the medical resources together to manage them like a single area in single region. It's much easy for the whole country to do this. But if it's distributed to the whole country everywhere, take infected to distribute the resources, it's getting very hard to do these things and to control the situation. Thank you.
Dr. Hayato, please. So Italy is a situation that how country like has a problem. So how to manage that, and your recommendation for the other countries that are behind Italy?
I think the only real results that we could evaluate was the evaluation of the number of affected patients in the first area that has been hit. That's the Codogno and the Lodi area. That was the part of our region that was closed quite immediately. And now the infection all over there is almost zero. So I think what we learned is that probably we should have much more strict rules at the beginning. So till 10 days ago, we still had too many people around the city. So and the restrictions were not really accepted. We still had some people that went jogging and so on. So I think that we should have more restricted containment strategy to do. Regarding the PPE, I know there are really very different realities. We have been quite lucky in our hospital, so we never went out of shortage of PPE. But in some other hospitals, they really had to struggle with it. At the beginning, we had longer shifts, but then we realized that on 8 hours or 12-hour shift with the same PPE was too much. So we had to reduce the shifts to 6 hours for intensivists and nurses and so on. And that, of course, caused an increase of the consumption of PPE.
Thank you, Dr. Hayato. What about in Qatar, Dr. Rizzoli, Dr. Peralta? So how did you manage this situation? What was the strategy for the country?
So Qatar is a unique country. It's different from China, very much different from Italy. It's a small territory, small population, and a strong government. So the restrictions were imposed very early on, and we learned as the days moved. Every day you would have one order in the morning and one rule in the afternoon and one rule the next day, and always escalating the restrictions. So what we're seeing here, there was an explosion in the number of cases initially, but now we're seeing almost the same numbers happening every day. We didn't see any death yet, and we're seeing a stable number of ventilated patients. But still, we're working with a fear that there will be an explosion. And anytime we're going to see lots of people coming to the hospital and requiring hospital resources. So PPEs are available, but they are limited, and the government is restricting access to it because of the fear that we still may face an explosion in the number of cases.
Thank you, Dr. Rizzoli. Dr. Scalia, so how are you dealing with PPEs at the Baltimore shock trauma, and how is the situation in Baltimore, Maryland, Washington region, please? Dr. Scalia, can you hear me? Okay, maybe you can have some problem, Dr. Scalia.
To me, come back, Dr. Scalia.
Dr. Scalia, there's something happening with the microphone. So let's go Dr. Raul Coimbra now, then come back to Dr. Scalia. Dr. Coimbra, so what's California doing to in this situation? How are the rules for social distancing, and how are managing the PPEs?
Thank you, Antonio. So obviously, countrywide, I'm sure all of you are following the news, and the United States, in the United States, the number of cases has exploded recently and will continue to grow as our ability to increase testing and decrease the turnaround time for tests improve. Not only the testing ability will affect the number of cases, but there is no question that the infection is spread rapidly throughout the country. The country is big, 320 million people. There are certain things related to the American behavior and the American society that prevent us from taking measures such as those taken in China. Most of the actions are local and state-based, although the federal government could make recommendations and was very delayed in any recommendation that was coming from them. The state governors in many states took charge and implemented movement restriction, social isolation measures, and containment. My state in California, we were fortunate, despite the fact that there are 40 million people in the state of California, we were fortunate to have a good leadership at the state level, and our governor, a week before what was implemented in New York, went to TV and determined that the state was in lockdown. Obviously, every county implements its measures, but the data shows that what was done in California, particularly in the San Francisco area, has led to a slowdown in the number of cases that are seen in their region compared to what happened in New York, which was progressive increase. So I agree that we are about 2 to 3 weeks behind what happened, what's happening in Italy and perhaps in Spain. And I think that we have yet to see this tremendous explosion in cases with a very large number of sick people coming to hospitals. As far as PPEs, you know, if I have 2 more minutes, I can present to you what I was going to present as a panelist. And can everyone see my screen? Can you see my screen?
No, not yet.
Can you share it?
Can you see it now?
No. Did you click share screen?
Yes, I did.
No?
Share screen. Desktop. Yes. Now, can you see it?
Nope.
No, when you click on share screen, you need to select, the best way is to select the application that you want to share, not the entire desktop, just the application.
Okay. Share. Okay.
And then,
All right. Can you see it now?
no,
No.
unfortunately.
Dr. Coimbra, send your presentation to Valeria. She's going to put afterwards, okay?
Okay. So regarding PPEs, I think we are on the same problem as everyone else. We are restricting use of PPEs to cases that are suspected or positive. Obviously, there are some alternatives that I would like to share with you that we have developed by thinking very creatively. All our faculties engaged in trying to find solutions to decrease the flux of personnel, nurses and doctors into rooms where we are housing COVID positive and suspect patients to avoid, you know, the excessive use of PPEs. So I'll share with you when I'm able to upload my presentation.
Okay. Thank you, Dr. Coimbra. Dr. Scalia, your comments from
Can you hear me
Maryland.
now, Antonio?
Yes. Yes.
Excellent.
Perfect now, sir.
The you know, the governor of Maryland acted very early and I think very wisely, and that has been enormously helpful. Our medical center and medical system acted early. Like other people, we shut down elective surgery very early, and we have no visitors to the hospital at all, and so that has helped some. The PPE has been a problem, both getting it out to people and then keeping enough stocked in. We have radically reduced the number of residents, for instance, that we let participate in the trauma resuscitations because we just can't afford to burn that much PPE. We're still a pretty high volume place, and we would run through that stuff and we would have none left. We've changed the workflow in the operating room to run fewer rooms longer. That seems to have helped some, both in terms of limiting exposure. And the other thing I will mention is we are already seeing, I'd be interested in the perspective of the guys from Italy and China. We're seeing a substantial amount of anxiety and depression in the healthcare workers. People that are usually very calm in their approach to the way that they do business have become very anxiety ridden, and it is making it difficult for us to create a workforce plan. It's a problem.
Yeah, Dr. Scalia, thanks for your comments. So I have a question here from Dr. Maimona from Jordan. She's saying that they have been in lockdown for 1 week. The question is, for how long should they keep the lockdown? So when should they start releasing people to do some activities? The economy, most of the countries has been hit badly. So I'm gonna ask the doctor, I can see here, Dr. Tina Garner from Norway. Dr. Garner, so what's your impression about that? So what are the rules in Norway, and for how long are you keeping the people home? And so what's the plan for the government for the future? Also, and after you, Dr. Beaufort from South Africa.
I think what the comments that have been made about strong leadership and strict rules and clear rules have been extremely important. And the fact that we had countries who were in this long before we started getting into it and getting that experience. Our government have taken, they were still a little bit behind, but then they took a very strong position and they've locked down the whole country. And I think maybe compared to some more Southern European countries, the Norwegian population is actually listening to rules. They're actually obeying. With very few exceptions. And I think social distancing, obviously we're in a country where that's possible compared to many other countries. But people actually do that, and we also see the same anxiety. And I think maybe one of the most important, that what the government has said is that they will have very, very strong restrictions until the end of April at least. This is the first. So until after, and in Norway it's quite holy to get into the mountains for Easter. And even not, so it's actually not allowed to go to your own cabins inside the country. You're not allowed to travel between communes because of the challenge that will pose to the healthcare in that commune. So this is really against what people normally do, but people will obey that. I think one more comment and then one question. One comment is, I think the anxiety, if one of as leaders, I think one of our biggest challenge and biggest work or task at the moment is to actually calm people down a little bit. I think what we saw in the beginning was a completely uncontrolled use of PPE, actually not rational use, and to actually give very straight, very sort of very clear rules on how is it rational to use your PPEs in the trauma teams and so on in situations where you can't have social distancing. 15, 20 people don't have to be all covered up and so on and so forth, unless you're absolutely sure that this is a positive patient and so on. To make clear rules for them, that actually saves a lot of PPE. The other thing, and that is also to my question, the anxiety also makes what we see in many countries, in many hospitals in the country, they make new rules for other patients. Even if we're not hardly struck yet, and our ICUs are filling up, yes, but there's still space, they start to challenge the quality of the care we give to trauma patients, other acute emergency surgical cases, because of fear of what is coming. And I think to make people stick with quality as long as you can, even if you have a plan B for when things are filling up. And I think that is our role now, so that we don't jeopardize the quality of other patient groups. And my question to the two presenters is, how have you dealt with, or have you actually have you data on how this has affected the care of trauma patients, other emergency cases, and so on and so forth? People who are young, who have their whole life ahead of them, have we seen the effect on that?
Dr. Zhang?
Yeah, actually, yeah, thanks, Professor Tina. Yeah, in Shenzhen, actually, within this time, actually, our trauma patients is decreasing, have decreased a lot. And for the management of the trauma patients, we have, if the patients in shock, patients is lost consciousness, we cannot find out if we don't have time to test the patient is positive or not. Or if the patient lost consciousness, we will treat the patient as the suspected patient, and then we will use a fully protection to go to dedicated lift, go to dedicated route, go to dedicated gate into the dedicated theater the dedicated theater is a negative theater to make sure all the protection environment is the best for the medical staff. And from the beginning until the end of the whole process, we were treating the patient as a suspected patient until we prove it is negative otherwise. So this is the way we have been doing. So far, we only have one cases with brain injury. We're doing these similar things, only one case so far.
Dr. Hayato?
So yes, the main concern is that it takes too much time to get a positive, to get a test. So we try to cohort the emergency cases through ultrasound and or CT scan, because the epidemiology is, the rate of infection is so high that we try to rule out this patient with the chest ultrasound or CT scan, and not trying not to avoid time. Actually, we had to reevaluate our hub and spoke network, mainly regarding trauma. So almost all trauma will be centralized in one hospital, but we still receive, as spoke, we still receive some injured patients. What we have seen is that, and what we did not understand is that we are just trying to get some data regarding that. We had a reduction of emergency general surgery that we cannot explain. Almost all the hospitals all over Milan started to have less bowel obstruction, less peritonitis, less perforation, and this is something that we do not really understand. We have seen some patients, for example, that have been staying at home peritonitic. So when they come, they are really bad, but still, as a total number, very few. We just started to collect the data regarding this issue.
So let me ask a follow-up question. Have you seen, sorry, it's Mike Abutanos, have you seen an increase in the violence? We have seen here in our hospital in Virginia, increase in intimate partner violence, and this is among our patients. And we expect that with a lot of the social isolation and telling people to stay home. So blunt trauma went down, but not our assault and violence. And I believe Baltimore has seen the same, about the Scalia can comment as well.
May I?
Yeah, Dr. Hayato, go ahead.
Yeah, no, this is something that we did not see yet in my hospital, but I just received a report this afternoon from another colleague referring that, yes, in her hospital, violence, domestic violence has been increasing. But you know, it's we do not have enough data about that because we did not analyze it. Yes, but this is something that is going to happen due to containment problems.
Dr. Scalia, any comments from Baltimore? Dr. Scalia, go ahead.
Antonio, if he's not there, can I ask a question to Hayato? Congratulations, Hayato, for the excellent job. Have you seen an increase in suicide attempt from the patients or relatives in Italy? We have a couple of cases here now in Qatar.
I don't have an answer yet, but so statistically, I don't know. It's mainly a gut feeling. This is something that because one of our surgeons moved to the trauma hub for this period, and he just referred me that it seems that there is a slight increase, but I don't have clear data about that. This is something it was unexpected, And actually, this is something we have been thinking about for the last 24 hours.
Okay, thank you. So you have a few more minutes. So I have a question here for Dr. Maida Velasquez, she's the chair of Department of Surgery at the University of Miami. Dr. Velasquez made a question about the trauma patients. So what are you doing to screen the trauma patients? Can be positive for coronavirus, and what kind of tests are you using? Do you have the rapid tests, or and please let me know. Dr. Velasquez, I think you are here as a panelist. Do you want to make your comments, your questions, please, Dr. Velasquez?
Just was wondering, our colleagues from China, there was a mention of testing the trauma bay patients that are coming through unconscious and so on, and then being able to know whether or not to route them through a specific isolated route versus the general route. And I was wondering what test is being used to do that triaging, starting from the trauma bay first encounter.
Dr. Zhang first, then Dr. Hayato afterwards.
Yeah. Usually we use if the patient is awake, and we can ask the history, and then we suspect it. For every case, we will do the test, and the test is the same as other patients, and it will take emergency test. It will take 3 to 4 hours to get the result, and we will get the result, get the test at the beginning. And then if the patient needs operation, if it can wait, we can wait for the result. If we cannot wait for the result, we will treat the patient as a suspected patient.
Thank you. Dr. Hayato, how are you screening trauma patients in Italy?
Yes, any patient, we have a pre-triage. So any patient had some, if the patient is awake, right? If the patient is awake and you get some information, you ask something if he has been respiratory symptoms, and you take your temperature. But in more severely injured patient, the only thing we do, of course, we do the test, but we had many concerns regarding this, especially at the beginning, because all the labs were overloaded by tests. So it took also up to 48 hours to get a test. So that's why we started very early to rule out patients with chest lung ultrasound and CT scan. That was particularly effective in the first area that had been hit. The colleagues from the Lodi area, they started to use ultrasound, lung ultrasound quite immediately. Because, you know, it's quite easy to detect the pneumonia through ultrasound. Because the characteristic of the ground glass area, they can be easily detected by ultrasound because it's subpleural. So it's easy to see, and it's bilateral. So, and almost all of them, then when you get the test, it's going to be positive.
Yes,
anybody
scan as well. What the chest CT scan as well. Yeah, and test both.
Anybody using the quick test for COVID-19, and the test come back the results in 15, 20, 45 minutes? Did you use this in China, Dr. Zhang?
Not in Shenzhen. I don't know in other cities or not, but not in Shenzhen. In Shenzhen, we usually a few hours, 3 or 4 hours to get the result.
How long?
3 to 4 hours. Emergency.
Okay, what about in Italy?
At least 6 hours in my hospital.
At least 6 hours. Okay. So, Dr. Scalia, can you make your comments now? Can you talk now?
About what?
About the situation in violence in Baltimore, and any precautions, special precautions during the trauma bay when you place chest tubes, intubation, tracheostomies, for example?
We have radically rethought our policy on emergency department thoracotomies. And whereas we were pretty liberal in the past, we are becoming immediately much more restrictive. This is to limit both provider exposure and to limit the amount of PPE that we need to use. The violence has not abated, so we are about the same as we have been. We'll see over the next few days or weeks. And we are using the combination of chest X-ray and chest CT to screen in patients in whom we are unable to get history.
Thank you very much. So we're going to have a few.
Antonio, can I ask a question?
Yes.
It's Enrique Ginsberg. It's Icky. Okay, Antonio. To the Chinese physician, the expert, I'd like three things. One, can you give us the lab test that you are running, the actual name as well as the Italian doctor, as to what lab tests you are using that come back within several hours? The second question to the Chinese doctor is, of the hospitalized patients that were tested and remain in the hospital because of their respiratory disease that screened negative for COVID, how many of them ended up screening for COVID positive after a second screen? And of those patients, that's question number one. And the second question, of those patients that were sent home with COVID negative tests, how many returned with COVID positive tests?
Okay, for the first question, in my hospital, that's have two kind of examination. One is the emergency examination test, another one is the general test. For the general test, usually will take about 24 hours to get the result. For the emergency test, we will get usually 4 to 6 hours, sometimes 3 to 4 hours to get the result. But I don't know exactly what's the brand or the production or the test brand. But I know the time is around 4 to 6 hours. Many of time is from 3 to 4 hours. This is the first question. For the second question is, for the negative patients is, excuse me, what is the second question?
Second question, in the hospital, those that tested negative, how many converted to positive during their hospitalization?
At the moment in my hospital we found that's about 3 cases. 3 cases negative at the beginning and then positive later. But in our experience, actually not in Shenzhen city, in other city we found is quite many. Is about, I think is about 10 to 20% or more than 20% patients they check negative at the beginning and then we check the second time, third time, sometimes the 4 times later, and then positive again. Yeah, so for the whole country, I think is around 20%, something like that. And so later on, they press every patient that do the trace CT scan as well to plus whether the test to confirm the diagnosis.
And of the patients that were sent home, COVID negative tests, how many returned with COVID positive?
Well, not many. At the moment, if the patient discharged from hospital in contact with the positive, I saw from the media report is only a few of them, not many.
Thank you.
Okay, thank you. So we are running short of time. So I'm gonna have all these questions that you have in Q&A. I'm gonna record. I'm gonna send to the panelists to answer. I'm gonna post on the websites from the Pan American Society, WST, and WCTC. Okay. So I have a question for Dr. Beaufort. Then I'm gonna end the slides from Dr. Coimbra. Dr. Beaufort, what situation in South Africa and are you dealing with shortage of PPE? So how are you dealing with the situation in South Africa?
Yes, Dr. Beaufort, your mic is muted.
Wrong button, apologies.
Okay.
Thank you very much. We've come to the party a little late. Our first case was recorded on the 5th of March travelers coming into the country. And until exactly 10 days ago, we had no local transmission at all. Currently about 700, doubling every 5 days. A few lessons we've learned already, and I thank Dr. Zhang, because a lot of the lessons we've learned have come from China, Singapore, Taiwan, and South Korea. Firstly, you need very, very strong and undiluted government leadership, so that our state president has been very active and communicating with the people. As an aside, we have 60 million people, pretty similar to Italy. We have a 40% unemployment rate. We have around 20% of the country living in informal housing with up to 10 to 15 people in a room. We have public transport, which is a taxi containing 16 people. Self-isolation and social distancing is not possible. Everything that's happened has gone from the president directly through the Minister of Health, who is himself a doctor. And the end result is we are, as of tomorrow, 3 weeks after the first case and 10 days after the first local transmission, in total lockdown. That means all stores closed, including retail stores apart from essential supplies. So you can go into a food store, but you may not buy an examination pad. All theaters, open parks, public areas, pretty much anything is closed down. All public transport is banned. All movement of anyone between the 9 provinces is banned. It really is a total lockdown. To follow on Hayato, jail sentences, mandatory requirement if you fail to isolate. There's a 5-day lag period with anything. The incubation period of COVID is 5 to 14. So whatever you do is going to take 5 to 10 days before the effects of what you do, even at the beginning, are going to be seen. So at the moment, we have got the PPEs in place, and much of what you're suggesting is good for the next 5 or 10 days, and we'll see what happens after that. This is the first of a series of webinars, and as I say, we're fortunately learning from people before we ourselves have a catastrophe that has already happened. So I look forward to reporting back in 10 days, 2 weeks' time, to see how effective our measures have been that we've learned mainly from China. I think that our trauma is unchanged. We have not seen family beating yet. We will see a great decrease in interpersonal because of the alcohol prohibition and complete prohibition on any meetings of more than 2 people. We look forward to seeing how this progresses. Thank you.
Thank you. Dr. Albutanos, some comments while you try to load Dr. Coimbra's slides, please.
I was just going to comment on what Dr. Beaufort just said, which is incredibly insightful. And this is the reason why we're doing this on a weekly basis, because we are all at different stages. And like Dr. Zhang said in his presentation, which I thought was incredible, the fact that the principles are the same, even though the areas, everyone is different. So we can learn from each other, but how they work in each individual situation may be different. And that's why this webinar that we have put together is important, so we can compare and just learn what applies to us. So we're going to keep on bringing different experiences and moving different countries around so we can get those experiences. A lot of questions. We can't get to all of them, but like Antonio said, we are going to put those on the web, get an answer, and then even those will change most likely with each situation. So I hope that gave Dr. Coimbra a little time to get his slides up.
May I just add one other comment, which again is local, but may make you smile. Our lockdown is coming on the 26th. The reason for that is very simple. Payday is on the 25th. Many people are paid in cash. If we lock down before today or tomorrow, we would have many of our population with no resources for the next month.
Thank you. Yeah, this is a big problem. So Dr. Coimbra, have your slides up?
Yeah, you can advance for me, right?
Yes.
Okay, so thank you very much. Just briefly, you know, the issue of PPEs and how you protect what you have and how you use them in a very smart way is a tough question. We are fortunate to have some young faculty that are savvy with social media, and they're doing research on these things full time, and came up with a couple ideas that I would like to share with you. You know, the N95 masks, no matter how hard you try to save them, they are going to end. And the supply chain is not going to be there for you to replace what you're using. So the picture you see on the right side of your screen is a regular CPAP mask that we adapted a filter in front that can be used, and it's actually superior to an N95 mask. So we started doing these things in the hospital, particularly for critical care areas, but this mask is small, doesn't cover the whole face. You need to cover your face with goggles or face shields. So the picture you see on the left is a commercially available larger mask that can be adapted with a filter in front and can be used for a prolonged period of time without damage to your face, because there is padding all around. Can you advance the slide? And depending what you wanna, depending on the purposes that you wanna use this mask for, you can adapt hoods on top, or our anesthesiologists are now using these masks as of today. They received 20 masks to use for all intubations and extubations when aerosolization is at the highest point and exposes them to infection. These masks can be used and immediately cleaned with a Clorox wipe and then be reused for the next case. So they use this the whole day, and at the end of the day, they send this to central cleaning, and then the masks are cleaned for the next day. So every anesthesiologist is having one mask, or every intensivist is having one mask, and cleaning it between cases and then cleaning it at the end of the day will save hundreds or thousands of N95s. Next. And then this is how it looks like if you want to add more than one filter, for example. Next. The other creative idea is we want to limit the flux of people in and out of ICU rooms as much as possible. And so we are exploring options to stay outside of the room and yet still provide care. So for the nurses, every time they need to administer a medication or just a drip, they got to go inside the room and deal with the infusion pump. So now we use extended tubing and are attempting to bring all the infusion pumps outside of the room so they can adjust the drips from outside of the room, not having to go inside the room to do that, and then use more PPE and new masks, etc. So solutions like this, if you really think about your processes on a daily basis in the hospital, whether it's in the operating room, in the trauma bay, in the ICUs, in procedure areas, you will see a lot of opportunities for you to limit potential contamination by using your creativity. Next. And finally, for those that don't have operating rooms or procedure rooms with negative pressure or negative airflow, there are some solutions in the market. I know this involves some investment. The machine that cleans the air and it's sensitive, is efficient or effective against 99% of bacteria and viruses, is commercially available, costs $7,000, and it's used for large environments. And the machine on the right is for the operating room, which uses the same principle, which is UV cleaning but in smaller environments, this is a machine that can sit in the corner of the operating room if you don't have the negative pressure rooms. So I just want to share with you some of the ideas that we are having. Obviously, we verticalized our OR utilization. We went from 9 elective rooms on a daily basis in our central OR to 4, and using the ORs more vertically, like Dr. Scalia said. But these other measures that I presented will hopefully help us conserve our PPE equipment. Thank you so much for allowing me to present.
Thank you, Dr. Coimbra. So, yeah, we need to finish this conference. Just to say, today's conference, we focus on prevention, lessons learned, how to prepare our hospitals, our universities. Next week, we're going to focus on treatment, okay? We're going to have intensivists have been treating patients, how to treat the critical patient in this situation, okay? So next week, we want to be a strong one, a lot of data about this. Remember, all these questions that you have here are going to send to all the panelists. They're going to answer, they're going to publish in the websites from all the societies involved in this. Thank you very much for all the panelists. Thank you very much for everybody that attended this conference. This is a Pan-American Trauma Society conference in collaboration with the American Association of Surgical Trauma, with the World Coalition for Trauma Care, University of Miami, and Virginia Commonwealth University. Thank you for all institutions to make this happening. Everybody stay safe. Thanks for collaborating, and see you all next week. Thank you. Dr. Butanos, any other comment?
No, just want to thank you and thank all our panelists, and looking forward for next week.
Thank you all.